Hi everyone, this is Doc Ina and this is my lecture on puerperal infection. To download my lecture deck for free, please go to my WordPress site, Docina Obigaine. This is the reference for my lecture. It's Williams Obstetrics, Chapter 37, Puerperal Complications. So this is the outline of my lecture. So basically, we will talk about the more common types of puerperal infection. So, puerperal infection is traditionally described as any bacterial infection of the genital tract after delivery, meaning this is any infection of the genital tract postpartum. Puerperal fever is a fever with a temperature of 38 degrees centigrade or higher during the puerperal period. Most persistent fevers after childbirth are caused by genital tract infection. Other causes of puerperal fever include breast engorgement, urinary tract infections, episiotomy and abdominal incisions, perineal lacerations, and respiratory complications after cesarean delivery. The respiratory complications are usually secondary to atelectasis following abdominal delivery or any surgery for that matter, which is caused by hypoventilation, and this is best prevented by coughing and deep breathing exercises. Postpartum uterine infection or puerperal sepsis has been called variously by different names such as endometritis, endomyometritis, and endoparametritis. But because infection involves not only the decidua but also the myometrium and parametrial tissues, we prefer the inclusive term metritis with pelvic cellulitis. So what are the predisposing factors for uterine infection? The single most significant risk factor for the development of uterine infection is the route of delivery, and this is most common with cesarean deliveries. To avoid metritis, we use single-dose perioperative antimicrobial prophylaxis. Risk factors for infection include prolonged labor, membrane rupture, multiple cervical examinations, and internal fetal monitoring. While other risk factors may also include lower socioeconomic status, bacterial colonization of the lower genital tract with certain microorganisms such as group B strep, chlamydia, mycoplasma, and Gardnerella. Here are some of the bacteria that are commonly responsible for female genital infections. So we have the aerobes such as gram-positive cocci, that's the group A, B, and D strep, Enterococcus, Staph aureus, Staph epidermidis. The gram-negative bacteria include E. coli, Klebsiella, and the Proteus species, and the gram-variable, which are the Gardnerella vaginalis. Others include Mycoplasma and Chlamydia, Neisseria gonorrhea, and the anaerobes that include cocci, in the form of Peptostreptococcus and Peptococcus species, and Clostridium bacteroides and Fusobacterium species and Mobiliuncus species. So here is a simple diagram showing to us the pathogenesis of metritis. So we have the normal flora or the bacteria that normally resides in the cervicovaginal area. So this bacteria will be inoculated in the uterine incision, especially with the presence of risk factors such as multiple cervical examinations, internal fetal monitoring, and prolonged labor. So, once this normal flora or bacteria inoculates into the uterine incision and under anaerobic conditions such as surgical trauma, sutures, the presence of devitalized tissue and blood and serum, then there is uterine infection and parametrial cellulitis and abdominal wound infection that ensues. Puerperal infection following vaginal delivery primarily involves the placental implantation site, the decidua, and the adjacent myometrium or cervicovaginal lacerations. The pathogenesis of uterine infection in following cesarean delivery is that of an infected surgical incision. So we have bacteria that colonize the cervix and the vagina that gain access to amniotic fluid during labor. So postpartum, they invade the devitalized uterine tissue. Parametrial cellulitis next follows with infection of the pelvic retroperitoneal fibroareolar connective tissue. But with early treatment, infection is contained within the parametrial and paravaginal tissue, but this may extend deeply into the pelvis. Fever is the most common criterion for the diagnosis of postpartum metritis, and usually the temperatures are commonly in the 38 to 39 degrees centigrade. Chills that accompany fever suggest bacteremia or endotoxemia. Signs and symptoms include abdominal pain and parametrial tenderness during abdominal or by manual exam. And usually metritis is accompanied by foul-smelling vaginal discharge or lochia. So how do we treat metritis? For non-severe metritis, we just give an oral antimicrobial agent. But for moderate to severe infections, we give or start intravenous antimicrobial therapy with a broad-spectrum antimicrobial regimen. Improvement usually follows after 48 to 72 hours in majority of patients. Persistent fever after this interval mandates a more careful search for causes of refractory pelvic examination, such as the presence of parametrial phlegmon, abdominal incisional or pelvic abscess or an infected hematoma, or a septic pelvic thrombophlebitis. All of this will be discussed in the later slides. The patient may be discharged home after she has been afebrile for at least 24 hours, and further oral antimicrobial therapy is not needed. So what are our choice of antimicrobials? For infections following vaginal delivery, as many as 90% of women respond to regimens such as ampicillin plus gentamicin. In contrast, anaerobic coverage is included for infections following cesarean delivery. So, in this table, we have the antimicrobial regimens for intravenous treatment of pelvic infection following cesarean delivery. So, the gold standard, of course, is clindamycin plus gentamicin. Plus, we can also include ampicillin, which is added to the regimen if with sepsis syndrome or suspected enterococcal infection. However, if the patient has renal insufficiency and we cannot give gentamicin, then we can give instead clindamycin plus aztreonam. We can also give extended spectrum penicillins, cephalosporins, vancomycin, which is added to other regimens for suspected S. aureus or Staph aureus infections. We can give metronidazole plus ampicillin plus gentamicin, and carbapenems. So next we have wound dehiscence. Wound dehiscence or disruption refers to the separation of the fascial layer. This is a very serious complication and requires secondary closure of the incision in the operating room. Most dehiscence manifest at about the 5th post-op day and is usually accompanied by a serosanguinous discharge. Next, we have necrotizing fasciitis. This is uncommon, and this is a very severe wound infection involving tissue necrosis associated with very high mortality rates. This may involve abdominal incisions or it may complicate episiotomy or other perineal lacerations. What are the risk factors for necrotizing fasciitis? Usually, these are patients who are obese, who are diabetic, and are hypertensive. Necrotizing fasciitis is usually polymicrobial and are caused by organisms that make up the normal vaginal flora. Infection may involve the skin, superficial and deep subcutaneous tissues, and any of the abdominopelvic fascia layers. In some cases, the muscle is also involved, and as such, we call this myofasciitis. Although some virulent infections, for example, group A beta hemolytic strep, develop early postpartum, most of these necrotizing infections do not cause symptoms until 3 to 5 days after delivery. Early diagnosis, surgical debridement, antimicrobials, and intensive care are very important to successfully treat necrotizing fasciitis. Surgery includes extensive debridement of all infected tissue, leaving wide margins of healthy bleeding tissue, and this may include extensive abdominal or vulvar debridement with unroofing and excision of abdominal thigh or buttock fascia. Next, we have the adnexal abscesses and peritonitis. An ovarian abscess is presumably caused by a bacterial invasion through a rent in the ovarian capsule, and the abscess is usually unilateral, and women typically present 1 to 2 weeks after delivery. Rupture is common in ovarian abscesses, and peritonitis may be very severe. Peritonitis is usually commonly caused by uterine incisional necrosis and dehiscence, ruptured adnexal abscess, or an inadvertent bowel injury at cesarean delivery. Peritonitis is rarely encountered after vaginal delivery, and many such cases are due to virulent strains of group A beta hemocyte streptococci or similar organisms. Abdominal rigidity may not be prominent with puerperal peritonitis because of the abdominal wall laxity from pregnancy, and the first symptom of peritonitis is usually adynamic ileus. Marked bowel distension may develop because of this adynamic ileus, and these findings are unusual after uncomplicated cesarean delivery. Now, if the infection begins in an intact uterus and extends into the peritoneum, antimicrobial treatment alone usually will suffice. Conversely, peritonitis caused by uterine incisional necrosis, as discussed subsequently, or from bowel perforation must be treated promptly with surgical intervention. Next, we have the parametrial phlegmon. Parametrial cellulitis may form an area of induration, and this is what we call the phlegmon within the leaves of the broad ligament. This infection should be considered when puerperal fever persists longer than 72 hours despite intravenous antimicrobial therapy. Phlegmons are usually unilateral, and they frequently are limited to the parametrium at the base of the broad ligament. In most women with a phlegmon, clinical improvement follows continued treatment with a broad spectrum antimicrobial regimen, and typically fever resolves in 5 to 7 days with the after institution of the right antibiotics. In some women, severe cellulitis of the uterine incision may lead to necrosis and eventually dehiscence. Extrusion of purulent material leads to intra-abdominal abscess formation and peritonitis. Now, for patients with parametrial phlegmon, surgery is reserved for women in whom uterine incisional necrosis is suspected because of ileus and peritonitis. Sometimes we do or there is a need to do hysterectomy and surgical debridement. Adnexa usually is seldom involved, and one or both ovaries can usually be conserved. There is often appreciable blood loss in these cases, and blood transfusion may be necessary. Now, this picture shows us a right-sided parametrial phlegmon where the cellulitis causes induration in the parametrium adjacent to the hysterotomy incision. Induration extends to the pelvis sidewall, and on bimanual pelvic exam, a phlegmon is palpable as a firm three-dimensional mass. Next, we have septic pelvic thrombophlebitis. This is a frequent complication in the pre-antibiotic area, but however, with the advent of antimicrobial therapy, the mortality rate for these cases have diminished. Septic phlebitis arises as an extension along venous routes and may cause thrombosis. Lymphangitis often coexists with this condition. Now, the ovarian veins may become involved because they drain the upper uterus and therefore the placental implantation site. This condition likely involves one or both ovarian venous plexuses. Women with septic thrombophlebitis usually have symptomatic improvement after antimicrobial treatment. However, they continue to have fever. There may be pain in one or both lower quadrants, but patients are usually asymptomatic except for chills. Diagnosis can be confirmed by either CT scan or MRI. There is no evidence for long-term anticoagulation as treatment for this condition. This is a septic pelvic thrombophlebitis where uterine and parametrial infection extends to the pelvic vessel as well as the inferior vena cava. The clot in the right common iliac vein extends from the uterine and internal iliac veins and into the inferior vena cava. The ovarian vein septic thrombosis extends halfway to the vena cava. Next, we have the perineal infections. This includes episiotomy infections that may cause dehiscence of the episiorophy, and this is most commonly seen in third and fourth degree lacerations. Other risk factors include coagulation disorders, smoking, and human papillomavirus infection. Local pain and dysuria with or without urinary retention are usually the symptoms of this condition, while in extreme cases, the entire vulva may become edematous, ulcerated, and covered with exudate, and eventually may also develop necrotizing fasciitis, especially if the patient also has diabetes or is obese. How do we treat perineal infections or infections of the episiotomy? Infected episiotomies are managed like other infected surgical wounds. So we drain the pus, we remove the sutures, and we do wound debridement. In women with obvious cellulitis but no purulence, then we can just do close observation with broad spectrum antibiotics. But if there's already dehiscence, then local wound care is continued along with intravenous antibiotics. Here is the preoperative protocol for the early repair of episiotomy dehiscence. So, we must open the wound, remove the sutures, and drain the pus if there's pus, and then begin intravenous antibiotics. For wound care, we advise a patient to do sitz bath several times daily or hydrotherapy. We institute adequate analgesia or anesthesia before we do debridement of this uh, perineal infections or episiotomy infections. Then, we scrub the wound twice daily with a povidone iodine solution. And then, we do debridement of the necrotic tissue. Then, we close the defect once the patient becomes afebrile and we note pink healthy granulation tissue. And then, of course, we do bowel preparation, especially if this is a fourth-degree repair. Next is toxic shock syndrome. This is an acute febrile illness with severe multi-system involvement. Usually, the patient presents with fever, headache, mental confusion, diffuse macular erythematous rashes, subcutaneous edema, nausea, vomiting, watery diarrhea, and marked hemoconcentration. The patients also may present with renal failure followed by hepatic failure, DIC, and circulatory collapse, and all of these may follow in a very rapid sequence, and therefore you have a very toxic patient. During recovery, the rash-covered areas may undergo desquamation. A staphylococcal exotoxin termed toxic shock syndrome toxin 1 or TSST1 was found to cause the clinical manifestations of this condition. This may also be caused by group A beta hemolytic strep infection and Clostridium sordelli infection. Colonization of a mucosal surface is the presumed source for this condition, and a delayed diagnosis and treatment may be associated with maternal mortality and even neonatal death. Principal therapy or the management for toxic shock syndrome is supportive while allowing the reversal of the capillary endothelial injury. And of course, we should give antibiotic therapy, and that will cover staphylococcal and streptococcal infection. Women with these infections may require extensive wound debridement and possibly hysterectomy. So lastly, we have breast infections or what we call mastitis. Parenchymal infection of the mammary glands or mastitis is a rare antepartum complication but is estimated to develop in up to a third of breastfeeding women. Risk factors include difficulties in nursing and mothers with outside employment. Symptoms of suppurative mastitis, as a rule, usually appear during the third or fourth week postpartum. Infection is usually unilateral with marked engorgement that usually precedes inflammation, such as this seen in this picture. So symptoms include chills or actual rigors, which are soon followed by fever and tachycardia. And usually the patient complains of severe pain in the affected breast, and the breast becomes very hard and very red in color. So what is the etiology of mastitis? Usually the common pathogens will include Staph aureus, especially its methicillin-resistant strain. Other commonly isolated organisms are coagulase-negative staph and viridans streptococci. The immediate source of the organisms that cause mastitis is usually the infant's nose and throat. So the bacteria enter the breast through the nipple at the site of a fissure or a small abrasion in the nipple. So how do we manage breast infections? If appropriate therapy for mastitis is started before suppuration begins, then the infection usually resolves within 48 hours. No need for any surgical treatment. The initial antimicrobial choice is dicloxacillin at 500 milligrams orally 4 times daily. Erythromycin is given to women who are penicillin sensitive. However, if the infection is caused by resistant penicillinase producing staph, or if resistant organisms are suspected while awaiting the culture results, then vancomycin or other anti-MRSA antimicrobial should be given. Now, if the patient already has developed abscess, then she will have to undergo surgery in the form of incision and drainage of the abscess, and then, of course, institute antimicrobial therapy. So again, in summary, we have discussed puerperal fever and the different puerperal infections such as metritis, wound dehiscence, necrotizing fasciitis, adnexal abscesses and peritonitis, parametrial phlegmon, septic pelvic thrombophlebitis, perineal infections, toxic shock syndrome, and finally breast infections. So that's it for my lecture. Thank you for watching this video, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.